Just checking the technology. It seems to be working. Thank you very much indeed. And welcome to this meeting of the Shropshire, Telford and Wrekin Integrated Care Board. Just some kind of stage management issues first of all, if I may. The agenda shows you that we are scheduled to finish at 4:15, but the observant amongst you will realise that allows 15 minutes for about 9 items. Now, even with the most skillful chairing ability, I doubt we're going to do that, so I'd ask you just to plan for a 4:45 finish. That's the intention. I apologise for that. If some of you need to leave before then, I fully understand. We also need to take item, where is it, 55, the Integrated Care Strategy Development of the Joint Forward Plan. I'm moving that up the agenda one, so that happens before the ICB CEO report. Nicola has some domestic issues that she has to attend to, so we will enable Nicola to get away slightly earlier than the agenda suggests. Now, there's lots of apologies and a few welcomes that I want to make. We've had apologies from Louise Barnett and Nigel Lee, who is well known to most of us, is deputising for her. Leslie Picton has sent her apologies. Cecilia Motley is due to attend in her place. I don't see Cecilia. No.
Isn't here yet.
Sorry?
She's not here at the moment.
No, I didn't think I could see her. So that, okay, hopefully she will arrive. We've also had apologies from Tracy Hill and Pauline Gibson. Now, some welcomes. Welcome to Tina Long, who will be the interim chair for Shropcom from the end of this month. Nuala is standing on and moving on to do great things in other pastures, I've no doubt. A good opportunity for me to, Nuala, on behalf of the board, thank you for everything you've done for the ICS, for the ICB, for Shropcom, and for health and care across the system for many years. You'll be missed, and wish you the very best for the future. I also want to welcome Kathy Pert. There is Kathy. Kathy is a non-executive director at Shropcom, but she's here through dint of being the chair of our strategy committee, and you're very welcome. We look forward to your contribution during the day and in time. And we've got others who will be getting involved presenting the patient story, who Gareth will introduce when we get to that item on the agenda. And I'm looking around the room, and I've just remembered Jackie Jeffries. Heather Osborne has stood down now, I think. Is that right? Are you her substantive replacement? You're very welcome. Good to see you. Have I missed anybody? Is there anyone else who I should welcome? I think not. Okay, let's move on. Some other, I suppose, general introductory remarks. I don't mean the appointment of Stacey Keegan as a Chief Exec for Robert Jones is a general remark. It's a congratulations to Stacey, who's been more than able interim Chief Exec at Robert Jones and Agneson for some time. Delighted, Stacey, you've been appointed the substantive CEO. And although he's not here and nor would he normally attend these meetings, an important appointment with Sath John Jones, the substantive medical director. Many of us know John, and it's great to have him in a substantive post, and we pass on our congratulations to him as well. It's been an incredibly busy time since last we met. We've been through the rigours of COVID and flu and winter, and in all of its with all of its challenges. And I just want to pay tribute. And we've had industrial action, I should mention, as part of the undercurrent that we've had to manage and deal with. I just want to put on record my personal gratitude to all of you and the people within all of your organisations for the fantastic, actually, spirit of camaraderie that we've witnessed during this period to help make sure that we've been able to provide the best possible services during some of the most difficult times I've witnessed in my time working in the NHS. So thank you, everybody, for your contributions, the hard work and effort of all of your staff. There are some other remarks which I could make, but when I do, I get chided later by Simon because I take things from his report So I'll leave you to talk about the ministerial visit, the publication of the ICS strategy and other things. But they are important events which have happened since last we met as well. So I've not had any notification of any declarations of interest, so I take it that the register is as was. And if you're happy for me to move to the minutes of the previous meeting held on Wednesday the 30th of November, I will do so. Comprehensive set of minutes, are you happy with their accuracy? Okay, and matters arising and the action list from previous meetings. There are a number of actions, and I didn't propose to go through the action log in detail, but there were 2 or 3. If you're happy to take the log as read, there were 2 or 3 I just wanted to pull out that caught my eye that seemed to me to be worthy of just a bit of discussion. One was the PCCC review of GP telephone access, which was an issue of some debate at the last meeting. I can't remember whether that's included in the PCC report for this meeting, and I don't think Niti is here today, although she was hoping to dial in later. But Nick, do you happen to know, is there any progress to report on that?
So I think the Primary Care Commission Committee meets on the first Wednesday of the month, so that would be covered when we meet next Friday, week on Friday, and then we'll bring it back to board after that. Please happy with that.
Okay, thank you very much indeed. We promised ourselves a discussion about population health management in March, but actually we'll be picking that up more and more as we think about our joint forward plan, etc., more later in the meeting. And we have deferred the discussion about the workforce plan, the people plan and workforce issues until the March meeting. Tracy Hill couldn't be here today. She craved our indulgence and asked, could it be deferred until March? I think having a little bit of extra time, Stacey, is probably not a bad thing for that piece of work, which again will feature prominently within the joint forward plan as well. Now, forgive me, there will be other things in the action log that will attract your eye, that you're interested in. You may feel the log is not giving you the kind of information you need about progress. If there are, would you like to say so? Pull out any issues that I've not referenced? Julian.
Mine's a small issue around the waiting times issue. I know that the minutes note that I asked about the circulation of the waiting times document was actually a circulation of indicative waiting times that was asked for. And I don't think that we're still, although we've had the waiting times communication about communications to patients, what we've not seen is an update around waiting times for different specialities. I think it was originally asked for 2 meetings ago, and then it was sort of raised in the last minute, so that's just...
Okay, an important point and a point you've made, you and Ian have made in the past. So Gareth, can you help us with that? Sorry? You can pick that up?
Yes, we'll close that down.
Okay. An offer from Gareth to deal with that outside of the meeting. Thank you. Any other matters from the action log? Very good, thank you very much indeed. We haven't had any questions from members of the public, so we can move forward effortlessly into item 53, a follow-up on the patient story presentation and the implementation of the new dementia model. This is a really important issue. We've talked about services for people with dementia in the past, and we are keen to learn more about not just the issue and the challenge, but what are we going to do about it? And I see the next bit of discussion about the implementation of the new dementia model, an opportunity to focus on some practical actions about how we take this forward. So Gareth, would you like to introduce this in more detail, and would you like to introduce our visitors who will be helping with the presentation?
Of course. Well, I think you've probably just taken my introduction at headline level, so I'm feeling Simon's pain. But if I can introduce George Rook, Helen White and Linda Vaughan, they will walk us through the new dementia pathway, and I think conclude with some specific asks for support from the board.
This meeting format is a bit impersonal, but you're very welcome, and thank you for joining us. I promise you we will be listening intently, and I think, George, are you taking the lead?
I think I am, yes.
Over to you.
Okay, thank you. Can you hear me? Yeah.
I think, can we just turn George's mic up a bit, or even turn it on? I don't know which.
Do we turn it on? Any better? Right. So, thank you for having us come and present to you. The product of several years of co-productive work across the area of Shropshire and Telford and Wrekin. And basically, we're going to set out a new vision, and I think it is a new vision, for a model for dementia assessment and post-diagnosis support in Shropshire and Telford, I should say, although most of the changes initially are going to be in Shropshire to bring us up to par with Telford. We're creating what I and friends and colleagues believe will be the best model for dementia care and support, potentially in the country, because it will have everything in it, not just one element and not another. We've put it together. I'm not going to call it a pathway, because people with dementia don't follow linear pathways. But a sort of Pandora's box of everything that people might want to dip into when they need it. It's been developed and co-designed by people living with dementia, unpaid carers and health and care professionals, working together under the aegis of the Shropshire, Telford and Wrekin Health Economy Dementia Steering Group, which I chair. So what are we trying to fix? People living with dementia and their unpaid carers have been saying for some time now that they are largely unsupported by the current system. And this was very much evidenced in the Health Watch Shropshire research that was carried out in 2019, which is really comprehensive and got a lot of views. And I'm deliberately not saying living well with dementia, because a lot of people, including me, feel it is not necessarily appropriate to say you can live well with dementia, but you can live as well as you can or as well as you choose. And our guiding principle, the support will be provided equitably right across the health economy, not just equally, because we've got to make sure everybody can access it. There's a lovely diagram, a picture I put in the slides, which of course you can't see at the moment unless you've got the paper copy. But it's the classic one of people standing on boxes to be able to see. Anyway, the best model of dementia care. And we're going to start off with a referral and pre-assessment support within general practice. We do see general practice as being the linchpin, the cornerstone, or whatever it might be, because that's where people start their journeys. Assessment and diagnosis will be within what the newly named service, Dementia Assessment and Support Service, DAS, which is hosted by MPFT. Post-diagnosis support in complex cases will be carried out by Admiral nurses, and we have successfully appointed 4 Admiral nurses in Shropshire who started work in December to work alongside the Telford and Wrekin service. And the less complex cases, or the everyday cases, I suppose, will be handled and supported by dementia navigators, who at the moment we envisage will be staff who are already existing within the dementia assessment support service. in MPFT. Another element will be a living plan, we called it. It's not a care plan because it's positive. One of the things that we are fighting against, in a sense, is to stop being disabled by care services, health, and to be enabled to continue to live well. So the living plan is all about, it's quite a large document, although people can complete as much or as little, and it's got loads of autobiographical information, lots preferences, hates, people who are closest to them, they might not be family, and all sorts of other information to help people to sort of be able to communicate both to themselves but also to other people, professionals included, what it is that makes their lives worth living and how to make contact with someone. Because people with advanced dementia, you might be able to make the best contact by talking about when they were a coal miner, for example. Another element will be the annual dementia reviews in general practice, not necessarily by a GP, but by staff who are sufficiently trained and experienced in dementia. There will be community peer support groups, which will be facilitated by the Alzheimer's Society Dementia Link workers, because people with dementia have said, and carers find this too, people with dementia have said that in the early to middle stages, the best, and often the only, but the best form of support is peer support. Being amongst quote-unquote equals who understand, who don't question, and just have a laugh together, basically. But they help each other as well. And then there will also be a carer respite entitlement. Now in Telford, they already, whoever, already provide a minimum 25 hours a year carer respite. To be taken however someone wants to take it. It might be regular, it might be occasional. We want to see the same 25-hour, if possible, in Shropshire as well. That all carers can look after their health longer and better. Too often I hear stories about carers simply getting to the end of what they can stand and breaking, and someone then being whisked into a care home, not of their choosing. It's really important. So, from your point of view, I think, we are doing win-win work. We'll be providing the support as and when it's needed. We'll be improving the health and well-being of up to 10,000 people across Shropshire, Telford and Wrekin, if you include the carers. We will be improving staff recruitment and retention, because who wouldn't want to work in the best dementia support service in the country? We'll deliver better value for cost, simply because people's needs will be being met, and they're not at the moment. There will be less GP appointments and hospital admissions as a result of this, and Dementia UK has evidence of this from studies they did 5 years ago. There'll be delayed entry to care homes. It is win-win. We have a number of challenges to the implementation. First one is, as you might not be surprised by, a major change to system working, because we're trying to get all the partners in the teams, in the system, to contribute together, so that people don't have to fight with telephone systems and referral systems and all the rest. Workforce. New ways of working is always a challenge, and we need to Some people welcome it, some people don't. Rurality clearly is an issue, especially when it comes to peer groups in far-flung communities. Well, you don't need to be that far-flung, actually, nowadays, to not have a bus to get you there. And, of course, demography and rising diagnosis numbers. We all know that people are living longer. Well, they were till 2 years ago now. That Shropshire has an older than average population. Finally, our ask of you, the ICB, is for board-level sponsorship to be the sort of guide, steer, driver, whatever it might be. Gareth has, I hope I'm right in saying, has agreed to do this for us and work with us. System decision makers need to be fully on board with this, otherwise it can fail. So we need everybody in the system, health and care and voluntary, to be on board. And thirdly, finally, that what we really would like to have, and I'm sure you have it in your power to get it, baseline data for dementia, people with dementia in Telford and Shropshire, so we can evaluate the success of our model in 3-4 years' time.
Thank you.
There you go.
Thank you very much indeed. That's a very compelling set of arguments for moving the service forward in a very comprehensive way. And thank you for the work you've done. Very inclusive, very clear. What I liked was a good description of benefits for patients and for residents and carers. That's always an attractive part of any proposal. So thank you for that. Let me throw it open. Are there any questions that board members would like to ask? Ian, would you like to introduce yourself?
I'm Ian Chan, I'm a GP. So what I'm seeing more frequently now, especially in the multidisciplinary team setting, is that there are more and more patients who present with multiple unmet needs, both social and clinical, because one, they live alone, secondly, they present late with the dementia. So they won't come to us as GPs as having dementia. They will actually end up in hospital, multiple patients because of self-neglect. They don't have any insight into own dementia. So the actual support for care is important. The aftercare is important, but the underdiagnosis of dementia is going to be something we need to tackle. It's got to come from an improved...
To rate on. Yes, Tina. Could you sit forward near the microphone? Thank you.
If I can ask the question. What do you plan to engage with various organisations? Because I work for Shropshire Community NHS Health Trust, and the community nurses and so on will be really interested in this, I guess. So it's what's your plan and how are you going to engage with each of the organisations? But I think it's a great idea.
Thank you. Any other comments at this point? So.
Okay, so answer Dr. Chan's comments first. We're doing a thorough deep dive into assessment and diagnosis, into the pathway. We've had some support from Cathy Riley to start that, and we're hoping that's very soon. And taking everything that you've said on board, because we know there are a whole group of people out there that are not diagnosed, that we're missing them, and that they're not getting the level of support that they need. And whilst we're focused on the prevalence rate from NHS England, it's more than just a number. It's about really getting the support that our new model will be able to offer. And I think we're looking, I want to preempt what's going to come out of that deep dive, but looking to something that's a little bit more inclusive so that you can get that support almost before your diagnosis, because quite often we're waiting until that diagnosis has been rubber stamped. So yeah, we'll be involving all of that, so we will be taking that on board. And in relation to your question, I mean, Donna Jones from Shropshire Community Trust has been actively involved with the Admiral nurses, but again, as we start to roll things out around that, identifying people with dementia, there's a whole piece of work that's been rolled out in other parts of the country that we'll be taking it on and seeing whether we can get people diagnosed in different ways by different people, so that they're not all sort of waiting on lists within the current DAS. So we'll be including everybody, so the more people that want to be involved in that, the better. Thank you.
Can I just add something for Dr. Chan? He mentioned individuals living on their own, and that is a significant concern. And I'll just drop in the fact that I found out the other day that the Admiral Nurse Service in Shropshire, the commissioning arrangement means that people living on their own without carers but with dementia cannot get that support. I'm not sure. I'm not going to go into that in any more detail, but I'm dropping that in because there are a third of people who have dementia live on their own, and those people do not get support.
Interesting, and clearly an issue that needs to be thought about and addressed very carefully. I agree entirely. I'm going to hand over to Gareth. Just draw this together for us and explain to us what you think we should do next.
So this was brought as a request from the board in terms of the mental health and specifically the dementia agenda in terms of an update on where we are. It's a really impressive piece of work the team's done in terms of where we've got to in terms of the next steps. And this is one of those situations which is George described as a win-win. The team aren't coming asking for financial support. This is the support of the system to make the decisions as they come forwards. So over the coming weeks and months, we will have that model of care finalised. And effectively, this is the opportunity, the first opportunity that the team have had to system level and seek that support. So when they do come asking for specific requests, people have got the background and they've had the opportunity to speak to the senior leadership. So this really was that opportunity to put it on with colleagues around the board, and the team will come back with specific requests through the usual governance in good order.
Thank you very much indeed. I mean, it's Gareth's absolutely right. This is a second discussion in this piece of territory as a board, and remember we've only been running for, 7 or 8 months, something of that order. And this is such an important priority. What I'd like to suggest, picking up your point, Gareth, is we have another discussion in, say, 6 months' time, where we can reflect on the things we've talked about today and actually ask ourselves whether the kind of progress we'd hoped as a result of today is actually being made, and if it's not, what we need to do to help its passage be eased. Is that okay? Are you happy with that? Are you okay with that? Yeah.
In relation to those patients who are living on their own, they will have the support of the dementia navigators, but also they'll have a new role, which is the case managers, who will be hosted by MPFT. So although they won't have access to the Admiral nurse, they will have alternative support in a different organisation and a different role.
Yeah, it's as you said, George, this is a real test for us as system workers, because there are so many different component parts that need to come together to provide the comprehensive suite of interventions that you've described. So thank you for highlighting that. We look forward to hearing about progress, and we look forward to seeing you again in some shape or form in about 6 months' time for a follow-up. Julian.
I'll just thank George. So my paths crossed with George over the last decade, really, and he's got a huge amount of patience in working with the system, and has been a tremendous advocate for patients and the public, and has been an advocate for sort of patient engagement, also patient involvement around healthcare. So it is amazing that like me, he's stuck through quite a few system changes, and he was involved well before me, and I'm sure he'll be involved well after me probably. But thank you, George. Good to see you again.
Thank you, George, and all three of you. Thank you very much indeed. Thank you.
Can I make a quick point, please, from me?
Yeah.
Yeah. Sorry about that. I'm Niti, I chair the Primary Care Committee, one of NEDS. Really lovely to meet you, and really lovely to hear your story. Just a quick one on assessments. So, sometimes things fall apart because assessments are not tailored to people with dementia. What we tried years ago was something called narrative-based assessment, and I don't know whether we thought of that along the pathway, but how you actually do the assessment. So a lot of the clinical questions you ask sometimes just completely escape people. Really thinking about how you make the assessment is really important to diagnose. Just a quick point for me.
Thank you very much indeed, Niti. Your point is well made. Thank you. Thank you again. Thank you very much. As I said at the beginning, I'd like just to shuffle the agenda at this point and bring forward the item 55, relating to the integrated care strategy and the development of the joint forward plan. Nicola's going to help us with this discussion. It's in 3 parts, as you see there. But Nicola, take us through this and draw to attention the areas where you want decisions or advice from us.
Thanks, Neil. I'll take perhaps those 3 items one at a time and stop for any key questions. But yes, this report brings together an update on the development of the integrated care strategy, a bit of a summary around the guidance that's been released for the development of the Joint Forward Plan, the JFP, and to just provide an update on where we are moving to with our engagement programme activities to support both the ICS and the JFP work. So I'll pull them out one at a time. So if we start, was the inequalities to access in preventative health conditions, of which there are a number, of course, that are listed in this document, but particularly addressing inequalities in access to that are key. And finally, within the inequalities aspect, that of deprivation and rural exclusion within our patch. So 3 key elements for health inequalities. The final element of that is the strong focus around some of our I guess, value-based principles for how we move forward, which includes supporting independence. And interesting, following on from some of the discussion we just had in our case study around dementia work, how we are supporting independence and self-care as a principle within our communities and better educating in that. There was a strong values push around best start to end of life processes, regardless of the age in which our communities approach end of life, and a big focus on children and young people, be that their physical, their mental health needs. Primary care access and urgent care and supporting our clinical strategies and the priorities that come out from that were also key, supporting value principles within the document. I'll stop at that point, I think, Neil, just to check in any key comments or questions from the integrated care strategy.
So a huge amount of work has gone into this. Some of us had the opportunity to debate the pre-draft at the last Integrated Care Partnership meeting just before Christmas. And I agree with Nicola, it's an impressive piece of work. It contains lots of data, lots of analysis of where there are gaps that we need to focus upon. And the committee recognised, however, that there's an awful lot to be done in terms of converting it into action. So with that caveat in mind, let me throw it open. I'd be interested in Andy Begley, David Sidaway-Oblique, Andy Burford's views of the strategy and your thoughts about taking it forward. Andy?
Yeah, thanks, Neil. I'll make a similar point. Is that on? I'll make a similar point to the one I made at the ICP. In fact, there's a huge amount of really good work going on in this area already. We know that. And I know we're on to this, but it's really important that the engagement process, the consultation, if you like, focuses on that work and addresses the question of how we extend it, how we grow it. Yes, there are gaps, and that also needs to be explored in terms of, especially around the wider determinants. I think a much neglected area. We talk about it a lot, but we don't necessarily bring it into ICB and ICP work. But go back to the point. I think it's really key that we talk to the partners who know about some of these areas, and many of those partners are the voluntary sector, about how the people are engaging with what's already there and what could be done to extend it and make it better. The good work that's happening needs a step change that's going to impact on the system as a whole.
Thank you, Andy.
In terms of comments around this particular paper, it's showing that the data's getting better and better. I think it is, Neil, as you reflected, actually a prime example of how we're working together across councils, across areas, and looking at Shropshire as a whole, which I think is a real positive. So there's lots of good things contained within this. The conversation that we had this morning at Chief Execs informally and previous conversations really for me centre around how do we use those wider determinants, Andy, that you were referring to then, of population health and well-being. How do we leverage that to greatest effect? So in terms of how do we work as stewards of place, for want of a better phrase, in relation to housing, in relation to education, in relation to economic prosperity, all those good things. Your reference to the community and voluntary sector is absolutely spot on, in terms of I believe that sector can reach where others can't, and make serious inroads into particular parts of communities that services simply can't engage with or struggle to engage with at the very best. So I think it whets the appetite for potential. I think, if I'm being really honest, I think we're a long way away from realising that potential of how we leverage everything that we've got within a place-based model to make the kind of improvements that I think are necessary for a step change within the system.
Thanks, Andy. David Sidaway.
Both comments around the wider determinants, but the thing I want to just focus on in terms of specifics is around the consultation, which is included in page 84, appendix 3 of our pack. And I'm really interested in how we engage, make it representative of areas down to as low a level as possible in terms of those that engagement, not at a macro level. It needs to be dealt with at a much lower level and across the geography. And secondly, I do believe, and I guess you would expect me to say this, that the councils are best placed to support and guide and help with that engagement. And perhaps a good suggestion might be through the health and wellbeing boards of both areas to give guidance and a steer, or in another form, but the engagement. And I think it's a real opportunity actually for the ICB to lead that engagement, but with clear support from both local authorities. Thank you, Neil.
Neil, can I make a point?
Yes, of course, Niti, yeah.
Sorry, I'm going to be in and out of meetings, so I just wanted to say something. It's a great document. It's picking up population health management. What's missing for me is the digital bits of this. What is the digital strategy we have to integrate the system, and how we're going to go about it? So I think there's a big missing piece here. While we've got data, there's a whole bunch around data analytics and how we present that, particularly to frontline practitioners. So the digital strategy really needs to come out strongly here. It's the only way you're going to get integration happening properly.
Yeah, it's a very good comment, and it's one that's been made before in the context of this draft, and it's one of the enablers that we really do need to pick up and accelerate. I just want to come back to the point about community engagement and consultation. I think it would be folly not to take advantage of the suggestion that David Sidaway has made and use the networks and the opportunities that health and wellbeing boards afford. And I'd be grateful, Nicola, if you... And is Edna here?
I think, well, I'll pick up some of that.
If you could pick that up. Yeah, but that point about the health and wellbeing boards, I think is a really good one, and we should build on that. Roger.
Yeah.
Just to pick up that point, great idea to engage with existing systems for getting that feedback. Other ways that I've seen this done is in the Black Country, that they're now sort of opening up their website to getting feedback directly from service users across their patch. That's another way of doing it. Their ICB chief executive has made a YouTube video, Simon, so he's now promoting the whole thing about engagement. And there's lots of ways of doing this. The other part of this, which I think is also important, is to engage with the service providers themselves. So we've got a very rich array of health professionals across the patch and social worker professionals as well, and it's actually to engage with them and understand their views about what they see as the pressures, not just from the the health population management side of things, but also what they see on a day-to-day basis.
Again, really good point. And somebody made the point earlier, I can't remember who it was actually, but involving the third sector and deep consultation there and getting advice and views and actually unashamedly asking the third sector to be vehicles for promoting what we're trying to do as well. Terry.
A fantastic paper, I mean, very much welcome it. I'm not going to speak to the sector as a whole, but what I would say is, we welcome that consultation and engagement, but much like other system partners, we are all stretched to capacity, and, this very much needs resourcing to be able to be really meaningful and effective. So.
Okay, thank you, Terry. Julian Povey raises his hand, then Andy, and then I'm going to move us on.
So my question is about the brilliant type of engagement. So the engagement of the plan is really to get the public support of the plan and see if there's any areas that we're missing, presumably. And then for me, the big step is actually then to see the bit that lies alongside that on page 80, which is then what we do with it afterwards, about developing the ICB system plan, and more so about the commissioning response, because presumably the commissioning response may have to include an area of what do we decommission to actually put the money into the areas where we're seeing the healthy life expectancy in Telford isn't broken down on IMD deciles, but presumably that's 10 or 15 years below the life expectancy decile, which means in some of the areas of Telford with the lowest, the highest levels of deprivation, the healthy life expectancy is going to be frighteningly low, really. And I suppose it's how do we then transact this, because this is all, this is just summarising the information, and we're going to get the public support, then that's what do we do then, how do we move that forward?
Yeah, I mean, Rome wasn't built in a day, but I'm absolutely clear that if this approach is to be meaningful, we're going to have to be very, very bold about the prioritisation of the use of resources. And we're going to have to move money into services or elements or interventions that we might not have done so before to the extent that we wanted to deliver our priorities. That might not be comfortable for everybody, and it'll take a lot of courage from people around this table in terms of making those decisions. But Julian, the principle that you espouse, I absolutely agree with. There's no point having a plan that's full of good ideas and then we simply say, however, in terms of implementation, we'll just apply the status quo. That would be meaningless. We lose a lot of trust and confidence from the public, and I would suspect from around this table as well. Thank you. Somebody else wanted to... Oh, Andy.
Just briefly building actually on something you said there as well, Neil, that brings us together. That I think, I'm not suggesting that we have to take the responsibility for decision making around this table, but I wonder whether we move very quickly from briefing and consultation with partners, the third sector particularly, and move from that kind of vocabulary into true co-design. And I think I said previously around commissioning the problem rather than the solution, and just how quickly can we configure ourselves to make sure that we're getting as much input as we can from all our partners, because frankly we need that kind of intel and insight that we won't find from within.
Okay, a lot of goodwill. I'm not quite clear. Help me, Nicola, I'm probably the only one. We're asked to note the update on the development of the draft ICS. What's the point at which the decision about the plan is made?
Well, the plan is approved
By the
signed
ICB.
off by the ICB.
Yeah.
This document is now, if you like, handed over to us to engage, to reflect, and to incorporate in how we now shape the next stage, which is the JFP.
Okay, the joint forward plan.
Yeah, which I can come on to if you like briefly. So
Okay.
we now have the guidance released for the joint forward plan. It came out on Christmas Eve. That was a happy Christmas present for me, and it's much more templated and structured than the integrated care strategy, as you might imagine. The JFP is intended now to be the how. So we have a picture on the what, it's now moving into the how. And this is where we start to see a focus much more on on what and how we will deliver our services, more on timelines, key trajectories, so getting into more detail. And associated with that, picking up on some of Nitty's point, is drawing in also the enabling strategies that will bring this to life, so workforce, digital, and those aspects to support it. There are 3 key principles that we're asked to follow within the Joint Forward Plan. One is to ensure that they're fully aligned with all the wider partners' ambitions. So as we talked earlier today about issues around HTP, local care programme, need to ensure that they are incorporated and reflected into our development. Also, we're asked to support subsidiarity by ensuring that local strategies and plans are incorporated. So again, work of the health and wellbeing boards, you know, understanding we're not starting from a blank piece of paper, but we've got to capture and draw that in. And, you know, finally, that delivery focus, objectives, trajectories, milestones in much more clarity. So as we're starting to work on that now, the timeline for the JFP lines up with the delivery of our operational plan, our finance plan, everything moving towards that date at the end of March of the financial year. The change that has happened in quite recent time, just last week actually, is we do now have a slight extension in the programme for the Joint Forward Plan. So whilst we need to submit a draft version of the JFP into NHS England at the end of March, we will start to receive some feedback and have an opportunity in dotting the I's, crossing the T's, continuing our engagement processes and our socialising of that document before we finalise it for publication in June. So that's to allow us to have a broader engagement process around that. If I can pick up a couple of points on the third and final element of this, the pack of documents, which is the big health and wellbeing conversation, our engagement programme that's being referred to. That this effectively sits across 2 phases of work for us, and phase 1 has actually already started. And phase 1 is intended to give us time to reflect on what we've seen in the ICS, gather up those broader strategies and understand that we've got all the right elements that we need to incorporate in the plan, and to have that opportunity to be discussing with partners. So phase 1 is helping to build what is our strategic intent moving forward. And phase 1 is very much about our key decision makers, our partner organisations. We've written to all partner organisations at the moment looking for those opportunities to come out, run through what are a series of questions and discussions we've been developing to test some of our thinking and to move forward with that. Phase 2 of that health and wellbeing conversation is very much focused around communities and our public discussions. There have been 5 community sessions sketched in so far that are occurring in March for Ludlow, Bishop's Castle, Bridgnorth, Oswald Street and Telford. But as we've discussed with the health and wellbeing boards and with some of our third sector parties, we are actively looking for opportunities that are already existing to go out, have this conversation, share the information. So this is happening in tandem with the development of our strategic processes as we speak.
Okay, thank you, Nicola. I find it hard to knit together in my mind all of the different parts of this plan, because we've got an integrated care strategy, we've got a requirement to produce a joint forward plan, we've got an operation plan, a finance plan and a people plan, all of which have to be drawn together. We also need to think as part of that of the means of delivery in terms of provider arrangements, etc. So there's a huge amount of work to be done between now and the end of March, even though at the end of March it's a draft plan for further discussion, iteration, consultation and refinement up to the end of June. So we're going to need a lot of help from you and the Chief Executives, Simon, just to enable us to think this through. We've got an opportunity at the board development session on the 22nd of February with a bit of skillful agenda preparation, etc., we can make good use of that time to help us get into some of these issues. But meanwhile, I think there's a really important and key element, which is the engagement. Engage. We just can't do enough of that from now on in, really, and previously, quite honestly. Are there any other comments about this? I mean, there's a huge amount here, and for students of the narratives and the documents, you'll have lots of queries and questions, Mr. Begley. I can tell by the way you're smiling wryly that this is not something that you've read in fine detail. But seriously, there's an awful lot in that, and officers, for want of a better term, I think you need to help us sort the wheat from the chaff. We've got to get into a position of having a clear, crunchy few priorities, which make sure that we differentiate the plan for this ICS from the old NHS-style plans and commissioning intentions that we've had in the past. So it's the task is not straightforward. It's not simple.
And there's been a lot of mapping work that's been happening here behind the scenes that will bring to those engagement sessions and to the development sessions. If we take an aspect around the financial plan, obviously Claire is all across it. You know, she understands what's coming out through that. Not at me. just as equally with our operating plan. You know, we are, if you like, almost pushing down kind of through this sieve, sort of continually drawing out the nuggets of what we need to be kind of putting forward to discuss. So there's a lot to share.
Yeah, there is. There's a lot of briefing to be done so people understand what it is we're trying to do. Ian, did you want to raise something?
Yeah, I think the engagement's certainly going to be very important. But I think moving on to the next stage, we need to consider about resource allocation. Because if we looked at during that workshop about initial engagement, we saw that in a joint needs assessment, Telford has got significantly higher in terms of inequalities compared to Shropshire. Now, if we're to resource and addressing the inequalities, what we don't want to see is that while you're addressing inequality in one place, you create inequality somewhere else. So I think that's going to be a consideration to be had. It's going to be a tough one. I don't have an answer to that yet, but I think that's something to be considered long term.
Yeah, I think the key, the point you make is important, and I think the principle is absolutely the right one. The key, though, is the long term. I think it's going to be very hard to come up with a redistribution of resource policy between now and the beginning of the new financial year, but I know Claire and others are thinking about how we do that going forward. Again, it's pointless having a plan that's based on health needs assessment and just allocating money, I was going to say willy-nilly, that's unfair, but allocating it against the same kind of priorities where we're trying to shift the way in which we work, shift the way in which we tackle the priorities of the ICS. So more about that in due course. And the other thing, if Nitty was, I don't know whether she's listening or not, outcomes. Plan needs to have clear views about outcomes. Nicola, thank you very much indeed. We'll speak more about this as a group in February, but meanwhile keep the lines open with organisations around this table and the Chief Exec's group in particular. Okay, thank you. Simon, CEO report.
Thank you, Chair. I'm going to take the paper as read and the papers that are in the appendices to note that support that. As ever with the formal board, bring an update in terms of the activity that's taken place since the last board in summary form that doesn't get picked up elsewhere on the agenda in any level of detail. Note in one of the appendices is the letter from NHS England on our last quarterly system review meeting. Sets out the areas of good practice that were recognised, but also the areas of challenge, and gives an indication of where we're at in terms of current performance and current functioning within the system. Clearly, it would be absolutely remiss of me in this meeting not to recognise the urgent emergency care pressures that the system has been under, the impact of industrial action, the impact of COVID, of flu, the challenges on workforce, the ambulance handover delays, and the pressures in our urgent and emergency care system. In recognising all of those pressures, it's absolutely appropriate for me to formally and in public thank each and every member of our health and care workforce our statutory organisations and chairs, chief execs, partners that have worked, and local authorities that have worked tirelessly over this period. I think there were times, in fact I'm certain there are times, and I've heard this from a local authority colleague, that over New Year and over Christmas I saw more of some of my partners around this table and around the urgent and emergency care gold calls than I did of my own family, given the pressures that we're under. But actually, the bit that I would say was the way, and one of the chairs mentioned this earlier, the way that partners have pulled together, the demonstrable impact of that effort, and the big strides that people have taken to say, how can we get to a better place in this regard and share the burden and share that pressure, has been just genuinely impressive, So important that I recognise that, important that I say thank you to colleagues, that I recognise the workforce that have delivered that care and have stepped up into that space again across the board, and important that I note that for the minutes going forward. Let also be clear that we continue to have pressures around the winter period. We're not out of winter yet. The latest cold snap will drive a set of activity, but we continue to need to have to work as partners, as a system, side by side, and that's the bit I think we've demonstrated really strongly in that space. So more work to do, but recognise the work that's taken place there. A couple of other things for me to touch on then. Myself and my chair met with one of the ministerial team, Maria Caulfield MP, only, was it last week? Only 2 weeks ago. So the ministerial team at the Department of Health and Social Care has set out a really clear approach of engaging directly with ICB chairs and ICB chief executives. It was the two of us with her and one of her DHSC advisors. I would say I think we felt it was a helpful, constructive conversation. Clearly the intent was it was the start of a series of conversations. It wasn't a one-off conversation. All of the things that you would expect were picked up, from urgent care to 78 weeks waits to system performance, to thanking colleagues for the work and effort that they put in over this time period. And we also took the opportunity to invite her up to come and visit, to look at some of the fantastic work that takes place across our system, but also to ask that the government engage positively and constructively with the trade unions to bring it into the industrial action that's currently in place. So recognise that you've already touched, Chair, on the appointments in our system, but I note that as well, and congratulate colleagues for those appointments, which is fantastic. I touch on some of the additional monies that have come into the system around the winter pressures, the Adult Social Care Discharge Fund and the Acute Discharge Improvement Plan. Again, I would say there, we just got a really strong demonstration of partnership working. Actually, we didn't have to sit and think, what shall we come up with as ideas? The ideas were already there. People were able to get around the table collaboratively, put those ideas together and do the legwork to make sure that we got our submissions in, able to draw that money down. And more importantly, actually, if we look at our no criteria to reside, if we look at some of the changes that we've made, we've seen a positive move in some of the targets and some of the performance in that space. And let's recognise, whilst those are targets and it's performance, actually it's better for the individuals that we're providing care for. And paramount in all of this is how do we get people out of hospital as quickly as possible when they no longer need to be in hospital? How do we stop them from getting in hospital in the first place if we can look after them in their own home? And how do we make sure we've got the right wraparound services and care to look after them as we would want our own family members to be looked after when they become unwell or when they need additional support? Also recognise the work around the virtual ward development, which has increased its capacity and continues to work in terms of how do we manage step down, so how do we get patients coming out of hospital into those beds, as much as the importance of those patients who are being stepped up in terms of their care and stepping into that space of before they get into hospital, getting additional support that stops that and prevents that escalation. I recognise challenges across primary care and certainly the impacts that Strep A had on primary care partners local, in terms of both local authorities through schools as well as general practice and also community services. Colleagues will remember that back in September I brought a paper around the development of the West Midlands Office of the Integrated Care Boards and set out high-level view of how we look to collaborate and how we're going to work on a sub-regional footprint. In the papers and in Appendix B is more detail in terms of that, and I think it becomes even more important as we get into the delegation of activities from NHS England. As NHS England reset their operating model and revisit their focus in terms of which tasks they delegate out and which ones they transfer and which ones they stop doing, then actually our ability to work as part of a West Midlands footprint becomes even more important to have consistency and best management of that. And I think going forward, as we look to right-size a strategic commissioner and be really clear in terms of what needs to happen locally and what can happen at a sub-regional level, then that best use of resource in that space is going to be as important. We've already heard and picked up on the integrated care strategy and the ICP, so don't intend to touch on that. I have put an update on here in terms of the delegation of some of the services from NHS England, but there's a more formal update on that later, so don't intend to touch on that now, because we can pick that up on the agenda. Other than to say it's really important that in all of these areas where we talk about delegation and we're shifting responsibility, we don't lose sight of the fact of the opportunity we've got to do things better for the residents that we serve. There's a real risk that we see this as it's a transaction of business. And it is, and we need to do that safely, and we need to do that well, and we need to make sure we manage the contracts in the right way. But more importantly, it will be a missed opportunity if we don't look at this delegation chance to think about how do we want to work in terms of dentistry, for example, community pharmacy, community optometry, general practice, in an integrated way in our system. So we just need to make sure we don't fall into the trap of, yes, we've got transactional business to do, we do that and we tick the box, and we miss the opportunity to really think about how those partners are a key part of any form of integrated care system, and we engage in that space. Recognising there are challenges in that as well, but we can pick up on some of those as we go through. The board has asked to note a number of those areas, Chair. The detail is in the appendices and in the paper, and I'll pause there, but happy to take any questions or comments.
Thanks, Simon. Very full report as usual. I just want to add 2 or 3 points about the Minister meeting, and for the record, describe some of the other things we raised. We advised the Minister of our continuing concerns about the pressures on primary care, and she listened carefully. We said to the Minister, although we're all grateful for the additional money to support for more discharges, we said that there was still a huge amount of work needed to be done for social care, and actually having the discharge money on a non-recurrent basis limits its value going forward. And we also said we crave for the NHS and social care, crave for a workforce, an integrated workforce, long-term workforce strategy, because unless we resolve the workforce shortages, then we're always going to be up against it. All of those points she listened sagely, sympathetically, and frankly, we'll see. I mean, if enough of us say those things, then who knows, we might get some change. We might get some change. Okay, any questions for Simon? Patricia?
Just on the transfer of services, particularly around pharmacy, ophthalmology and dentistry, which I welcome because I think they're extended primary care services, and it makes sense that when one is planning and commissioning primary care services, that's done in the round. It affects directly our population and population health. I guess my nervousness in that transfer isn't in that it's a transactional piece, but that we do our due diligence to make sure that the resource that comes across isn't subject to evaporation in the process of transfer. Yeah, and that also, it's not just the resource itself that doesn't evaporate, but the skill, the capability to commission those kind of services are also transferred as well.
That's a really good point. If Claire Parker were here, and she can't be unfortunately, she would say that when primary care responsibility, commission responsibility moved to the CCG, Julian Povey will no doubt testify to this, there was, to use your word, an evaporation. And it caused quite a lot of difficulty in terms of keeping things together and moving forward. So really good point, and I'm sure that's been picked up.
So it is, and I probably pick up on this now, because I would also say it was a backward step when it moved away from being commissioned locally, because how do you commission integrated pathways if what the key parts of that sit somewhere else? But Patricia, in terms of your specific points, two aspects. The first being one of the reasons for the sub-regional arrangement between ICBs is that scarce resource in terms of people and skills, being able to keep that on a West Midlands footprint, and BSOL are being the host in terms of the pay and rations of that, but they're clearly part of the West Midlands collaborative to work in that part, means we're not trying to split small numbers of people into 6 ICBs and then say, yes, we get half a day every other week on community optometry. So we've tried to think through that. I think you're absolutely right to flag the challenge around budget and money transfer, and the due diligence piece that Claire, Gareth and Claire Parker are on is absolutely underway. Whether that will give us the right amount of money in terms of what we need going forwards, then that will be an ongoing challenge, I think.
But something that we would, I guess, as a board, in terms of standing shoulder to shoulder around advocating and flagging strongly.
Yeah, indeed.
Andy, I'm sorry, Jim.
I mean, we did transfer over primary care, and it's not only just the evaporation of staff, it's actually the change in attitude of NHS England in terms of demanding more than they were delivering before. So I think we've got a twin track of them reducing the staff, reducing the knowledge base, and also saying, hang on, we want X, Y and Z. And you say, well, you didn't produce that for the last 4 years. And they go, well, tough, we want you to do it. So I think there's a massive risk there.
That's a helpful piece of advice, actually.
Yeah, I mean, and part of that goes back to the importance of keeping colleagues who are transferring out of NHS England. So actually we've got some of that organisational history and memory working on that footprint in terms of what has been delivered over the previous 4 years. Of course, previous Director of Primary Care in Cheshire, I absolutely understand the dental contract in more detail than I've ever wanted to be able to count UDAs, and the same with community pharmacy. But that's the space that we're back in. We just need to make sure there's that point that Patricia's raised and I've flagged. We need to make sure we use this not as a transactional piece of business, but how's this a integral part of an integration strategy about joining up what we deliver in the community to better meet the needs of our residents.
Andy Burford?
Picking up on your point, Chair, of the fact that the discharge funding is non-recurring, and the point you made to the Minister, it is a continuing worry, isn't it? I mean, we're now 2 months away from when that finishes. And I note the comment in the report that continued funding will need to come via the Better Care Fund. Now, I've just taken the chance to have a look through the items in the Better Care Fund, and I still don't see where it's coming from in there if you're not going to actually take it from important preventative items within that fund. So we have got problems in 2 months' time. I don't want to scaremonger, but we've got through this winter as a result of really good collaboration, as Simon was saying, but also that extra funding. And we'll continue to have good collaboration, I'm sure of that, but we won't have that funding, and that does worry me.
Yeah, I think it's a very fair point. I mean, there was a review of the Better Care Fund due for completion at the end of the last calendar year, was there not? Yeah. And I don't know what the outcome of that is, but I suspect we're going to have some difficult discussions about priorities against it. Whether that includes discharge funding or not, I wouldn't care to comment. It depends what else we think we need to resource through it. Gareth?
We actually did at the end of the last calendar year, there was due to be a review of the better care funding and all of the hospital discharge cost pressures with the intention that we would deliver all of that within the funding envelope of the BCF. Unfortunately, that wasn't successful in terms of being able to come to a conclusion that we could bring forward to the Chief Executive for review. Funnily enough, Tanya and I, with Sarah, spoke back end of last week with a renewed appetite to complete that work.
Well, it's added importance.
Added importance. It's a slightly changed context because I think, and it may be that I've just seen an email literally just before walking in here, that the additional non-recurrent funding has been allocated for 23-24, non-recurrent, and we need to get the kind of the Blue Peter thermometer that tells us what do we have, BCF plus the non-recurrent.
Okay. So there might be some relief. We can guarantee it won't be enough. We're going to have to look to prioritise it within our existing resources, aren't we, by the sound of it?
But if I may, it's a very specific ask, which is we will come back to the Chief Exec, and I suspect through to the Health and Wellbeing Board with that prioritisation.
Yeah, that's the proper route as far as I can see. And Andy, David?
To the Blue Peter approach, and our predictions are with the one-off funding allocated to the councils and potentially to the ICB, maybe it's not a one-off in the ICB, I'm not sure, we're predicting for Telford and Wrekin only a 6 million gap come the 1st of April, to be absolutely clear the risk that the board are facing in terms of managing this system. Thank you.
And I'm sure there'll be a similar risk assessment from Shropshire, so it just adds some colour to the point which Andy Burford made. Roger?
You mentioned in your report the acute discharge improvement plan, and that's improving the discharge process. Is that revenue neutral, or does that require more money?
Yeah, so there's two parts to that. There's I'll use the numbers because that allows us to differentiate. There's a 5.1 million allocation that was made before December, in December. That is effectively revenue neutral. We've committed to additional capacity, predominantly in domiciliary care and social care, that this funding will support. And then there was a second allocation last week of 1.7 million that we're still working through as partners, that both local authorities and Shropcom have come forward with proposals. What we're not clear on yet is how readily we can deploy that and use the entire 1.7 million. But those will effectively be funding provided against costs incurred, so they will be revenue neutral. But they are genuinely bringing additional capacity, and it is worth acknowledging the significant step change we've seen in terms of the complex discharges through to the local authorities and Shropcom as a result of some of that funding.
The only other bit I'd add, Chair, onto that really quickly, I'm sure Patricia might want to come on this, is the other bit it's enabled us to do is really get into the right space with the integrated discharge team. So the step up in terms of that integrated discharge team, working as partners in the system, provider-led, with local authorities in the acute trust, that discipline, the granularity, the level of detail is absolutely the space that we need to get in. And this work's enabled us to really get under the skin of that much more than previously.
Yeah, in terms of numbers, detail, and actually the upstream delivery of prevention to patients, so that we're not ending up putting them in places, in placements that actually don't need to meet their needs and further disable them in the long term at greater cost to the whole system. Okay,
Ian, last word, and then I'm going to have to move us on.
The importance is not just about what happens 3 months' time, it's about what's going to happen next winter. So there's a big piece of work at the moment pushing ahead with the virtual ward to make sure that it works. And Nick and myself, we've been looking at the planning for next winter, because we know it's going to be another challenge, so we've got to plan ahead.
Yep, that's a good point, and build on some of the recent successes we've had with the virtual ward.
Yep.
It's getting stronger, the capacity is expanding, but we've more to do. Fantastic, okay. We're a bit behind schedule, but I'm going to take the item 56, the Hospital Transformation Programme update. And Nigel, I'm going to ask you if you could try and shave a few minutes off, if you don't mind. This is one of the 6 big-ticket items. I think that there won't be a single person in this room, including our technicians, who have not heard us talking about the Hospital Transformation Programme a lot over the last while. We thought it was important that the board simply received an update on the progress. And over to you, Nigel.
Thank you, Chair. I will not go through the slides by rote. They start on page 95 of the appendices pack. Just if I may, I was going to draw out a handful of key points. I think the first point is, it's a really exciting stage of the programme. having received the approval for the strategic outline case last summer, then we're absolutely making progress on the outline business case, the second of the 3 major stages. I think the key points I would want to reiterate is, yes, it's a significant programme, but it is really important that it's seen as one programme amongst the work that we're doing as an integrated system. And I think Nicola described that, as well as linking them with the work of the Joint Forward Plan. I would especially point out the very close working relationship we have with the local care programme, Patricia's teams who is the SRO for that. We're represented, and we'll see that on the governance side. We're represented on each other's programme boards, but I think more importantly with some of the detailed work that we're doing together on that. I think the second point is we do have obviously some really quite important and fundamental aims and the plans that are underpinned by that. It's really important that we retain and utilise optimally the 2 thriving sites. It is absolutely about improving care for everybody. And as we've seen, and colleagues will talk in due course, the pressures that we're seeing across both urgent care and planned care, including cancer, is really, really important. So we're looking at the entirety of that. Throughout this, though, we've been absolutely led clinically by our clinical teams and working with national and other clinical bodies. So the improvements in care is also absolutely focused on outcomes, and again, colleagues mentioned that a bit earlier. The governance framework that we've had in place and we've continued to develop as we've gone through is absolutely integrated, whilst myself as the SRO and chair of the programme board and our internal committee, there is obviously the focus on SAF. Then along the way, and including representation to the Integrated Delivery Committee and our HTP committee has got a range of different partners, and that is both the ICS, key partners as trusts, as I've mentioned, but also organisations such as Powers Health Board, who are not only a commissioner of our services, but also have their own strategic developments that we're interrelating with. The progress, as I've mentioned, is really, really important, and we're making good progress on that. Our intention is to go through the appropriate checks and review processes to submit the OBC for the summer Joint Investment Committee for the OBC, and then continue swiftly on then with the full business case, which is aimed at the end of this calendar year. We've mentioned involvement and engagement, again a common theme throughout other parts of the Joint Forward Plan and others, and that's obviously really, really important that we continue to do that work, and we are doing that. Clearly there is plenty to continue to do, and it will be a long-standing programme that will continue to work very much hand in hand, and we're really grateful to partners across the ICS, the voluntary sector, our community and public, for all of the support for that. And I think the final one, just to reiterate, this is absolutely got clinicians at the heart, outcomes and experience for patients at the heart of this. We held an event last night, an About Health event, which was a live stream event, which I was really grateful to my clinical colleagues for really emphasising some of the key questions that we know are being asked by a range of our communities. But it's again, I know that our clinical teams are really excited by the opportunity to continue to improve care as they work across the system. Thanks, Chair.
Thank you, Nigel, very much indeed. I mean, we know that in some quarters HTP is not supported, but nonetheless we need to move forward. We need to explain more and more to communities about what the new service will look like, and I think we're all agreed that alongside HTP, Hospital Transformation Programme, we need to think about the local care programme as well, because they're absolutely bolted together, or at least they should be. And it's in the latter part that I think there's so much of explanation to be done and so much opportunity for communities around our system in terms of their future health and social care, actually. And so I'd be grateful if, when we have discussions around this table and elsewhere about HTP, it's HTP and the local care programme, so they are seen to be one and the same piece of work. HTP and the local care programme are the biggest catalysts for change, I think, that we have available to us. And we've got government backing and huge sums of capital to enable us to invest to take this forward. We owe it to our residents to make sure we take advantage of that. We owe it to our residents to make sure that they feel part of the process of designing the new service, which isn't just about hospital rebuilding, it's about the whole fabric of health and care that we want to provide going forward. And we don't need a joint forward plan to articulate that. We know that, but it needs to feature in the joint forward plan. But that would be my personal exhortation to the planning groups to bear that in mind as we move things forward. A very brief, succinct, to the point presentation from Nigel. Thank you. Are there any questions, comments? Nuala and then Patricia.
I'm not sure if this is on or not, but just reflecting, Neil, on your comments, you're absolutely right to acknowledge that HTP is not supported elsewhere. And I think, in particular, we have failed to get across the message of the benefits that come from it. And Nigel, I heard what you said about the engagement event last night. I think we need more and more of that, but we do need to be able to explain in clear terms what the advantages are going to be for our population, because at the moment there's a large part of our community, mainly around Telford and Wrekin, that don't see it as an advantage. They believe and feel that they're losing something. Yep. Now, we know that's not the case, but I think we haven't made that case explicit enough. And so I would just say at this meeting, we need to do more, because those who oppose the plan, and I saw that there was a petition with 22,000 names delivered to Downing Street recently opposing the plan, their voice at the moment, I think, is louder than the voice of those who are advocating for this transformation. So I really strongly feel we need to work harder at getting that important message across, because we know it is right for our population. But as long as people fear it and are anxious about it, we're going to have that opposition.
Let me take Patricia's question or comments and then hand over to you, Nigel.
So I absolutely welcome the idea that we need to change the language, and I think that starts actually with us, Neil, in the ICB, so that we're not talking about the hospital transformation programme. Actually, we're talking about the strategy for the ICB, which is about strong, good local care, of which acute care is a component part. And Nigel's absolutely right, the local care programme and HTP are joined at the hip. But we need to stop thinking about centralised high-level acute care. There is a good evidence base for it. Saves people's lives, but the people that give people back their lives is primary care, community services, mental health and social care. And actually what we need to do is to absolutely, as Nuala pointed out, be able to articulate that. The way that healthcare and delivery is going is hospitals without walls, patients being given high levels of subacute care within their homes, and we need to be able to describe and articulate that the 90% of care that's delivered to people is within the community. And we need to get MPs as exercised about community-based delivery of care, joint health and social care, as they are about buildings and hospitals. That is not the way that healthcare is going. Hospital acute care, bed-based care has its place. That needs to be centralised to be able to deliver people the right kind of care needs. So, yeah, I think we need to change that language so we talk about local care, of which the hospital is a key component part.
Julian, I promise I'm going to pass back to you, Nigel, in a moment.
I suppose for me that's where I think the joint forward plan and the ICP plan comes in, because what makes people more poorly in Telford and have worse outcomes in Telford isn't where the hospital is, it's the wider determinants of health. And I think we as a health community in Shropshire, Telford and Wrekin need to send that signal by, in the plan, making sure we're targeting resources of where that's needed. And that means moving more resources to attack those wider determinants of health, to improve the health outcomes in Telford through interventions in the community and through primary care, rather than where the buildings are. So I think we've got a very good opportunity with the public engagement for the ICB plan and then the development of forward plan and then the commissioning intentions to show that in fact we recognise that and we recognise there are worse health outcomes in Telford, but to improve those, it's by doing it outside of hospitals.
Well said. Good point, thank you. So Nigel, taking those points together?
Absolutely. So I think it's, I'm probably going to just repeat what Julian said about just reinforcing the whole system approach, and therefore that the HTP will succeed as long as it's part of the overall plan of improvements that we have. And I'm you know, it is really important, and I know, you know, Katrina, Louise, all of us at South are absolutely wedded to that as being absolutely pivotal. And I think just on Nuda's point, I think what we have looked to do is reinforce some key messages, but actually it's been really useful to reflect on some of the feedback we've got given from a range of different both stakeholders as well as the public, to make sure that those messages are clearer in what it is that we're doing, why it is that we are needing to do this, but also why it is better. And those were the messages that we really concentrated on last night, and will continue to do so across a range of different environments. And as I say, I'm really grateful. There's our Public Assurance Forum. I think with Meredith, we were able to join the Equality and Involvement Committee last week, which again was really instructive, good opportunity for discussion and feedback. So we will continue to do that to make sure that, again, the right people hear those messages, but also it's from the right people, the people that know about the services best, working with colleagues.
Thank you. Meredith, anything you wanted to say about the discussion with the Equality and Involvement?
Thank you. It was a very helpful discussion. We learned a great deal. I think we were able to give some advice and suggestions about reaching into parts of the community that won't necessarily be active in coming forward, so reaching more deeply was a very useful part of that conversation. Also, I would just like to say I understand Nuala's view about persuading or explaining, articulating, but I think we also have to recognise that some people don't want to hear it. And we mustn't beat up ourselves because they're resistant. So we just carry on being robust and clear, and taking every opportunity to set out the rationale for it all. I think that's important. Ultimately, we won't be able to persuade everyone.
Good point, thank you. Andy?
Yeah, you'll be pleased to know I'm not going to rehearse the arguments about Future Fit and the Hospital Transformation Programme here, except to say this, that I think I don't want the views of those opposed to HTP to be characterised as in some way obsessed with buildings and hospitals. Quite the contrary. Some of us argued very early on in Future Fit that the two things were intimately linked, and for one to succeed, the other had also to succeed. That was before any model was developed in terms of how Future Fit would be developed. That link was broken during the course of Future Fit. It became just the thing we didn't want it to be, which was a focus on the hospitals and the idea that that could solve everything. Now we're in a position of still feeling that that element of local care, which you talked about, Neil, would have to be developed in a way that represented a step change in the services provided. But as I think was mentioned, that requires other areas to be decommissioned. I see no prospect within the finances of the ICB at the moment of that being on the agenda. Quite the contrary, we've got savings to make. So I think we have to get a little bit real here. I don't want to go over the pros and cons of the HTP programme here from the perspective of Telford residents, but you've got to recognise that there's a lot of work to be done there to convince people that there could ever be a real step change in terms of the good work that's going on in local care to a degree that it would actually change the whole picture of acute care in Shropshire, Telford and Wrekin. I don't see that in the near future. I'm afraid. I'd love to, but I don't see it.
Well, thank you. And you're being entirely consistent with your views about Future Fit HDP and the community service opportunity, which, as Nuala pointed out, has probably got lost in the telling in the past. I mean, we're going to have to make some difficult decisions about priorities, and I think we've got actually quite a bit to learn from local authorities. You are past experts at managing to do that and finding ways of producing balanced budgets, and I think if you've got some secret nuggets that we can steal, then we would unashamedly use them. You know how to prioritise, you know the importance of prioritising, and we have to learn from that. We have to find ways of doing just that. It's very difficult, but frankly, we can't make the progress we want without, frankly, the courage to take that on board. Look, I'm going to draw a line under that and thank Nigel for his update. Please keep us updated, Nigel. And we are scheduled to have a 10-minute break. Is everybody happy to have a break? Yep, I see lots of nods. 10-minute break. Let's reconvene at a 1:45, which is an 8-minute break. But thank you. That includes our third sector colleagues as well, who formed the subcommittee by the look of it. The next item is the Integrated Care System Performance Report incorporating people, finance and long waits. It includes lots of other things as well. Now, I'd like long waits. Gareth, give us an overview of the operational performance, if you would please. And I want to draw in chief executives, get their observations and comments, and then we'll move into finance. And we don't have Tracy Hill here to focus on the people stuff, but let's see if there are any comments about that as well. Gareth, the floor is yours.
Great, thank you, Chair. So colleagues will have seen the paper and appendices, and given the level of content in there, I definitely won't walk us through page by page. In fact, what I might do is take the paper as read and then give some updates on what's happened since the paper was submitted to the board, because there have been some really interesting developments. Simon's touched on some of the UEC performance issues and response over the winter period, and can't pass this opportunity but to reflect and repeat the comment in terms of the support of partners and the focus that's offered for our patients in the system, and pass on our thanks again. There is no doubt that the performance during November, December and January has been really challenging, with some of the worst performance measures that we've seen. The ambulance response times, the ambulance attendees have been a real challenge for us, and there's been a really deeply impressive response, as Simon's described. That's not to hide away from the fact that there have been some really challenging manifestation of risk, 12-hour breaches within the ED department, the time that people are waiting for ambulances, patients waiting for access to GP care and primary care as well. The system across the board has been significantly under pressure. In response to that, the business as usual actions have been taken. We've been a system critical incident twice over the period since the last board, and all of those actions have been in place. But as you would expect, there have been additional activities that have been carried out within the system across all partners to reflect the unique challenges that we faced. The Winter Flow Summit was held just before Christmas, which agreed a number of specific actions which have had a material impact on the performance since. Those included an expansion in primary care appointments, with I think more than 30 of our practices offering additional appointments to patients in primary care. The additional deployment and resource of capacity that we touched on in terms of the Adult Social Care Discharge Fund across local authorities and within Shropshire Community Trust has had a significant impact on the complex discharges that have been able to be moved through to the pathways that patients are being cared for where they should be. We've also had significant support from Raja as well in terms of the provision of temporary beds, additional temporary beds through some of the most difficult periods over the course of the Christmas and bank holiday periods. We've deployed a system control centre which oversees and provides drive over and above that already within the system to the urgent emergency care flow. And SAF has responded in many ways, including the 26 additional beds that we flagged at the last board were coming on stream. Those are now in place in the acute floor reconfiguration. Simon's already touched on the virtual ward capacity increasing from 30 to 50 during December, with plans to move to 75 by the end of the month. And the single point of access has had a significant impact in terms of stepping up the number of patients that are avoiding coming into ED in the first place. They're averaging something like 6 per day, now that's up to 25 per day. So there have been a number of significant improvements, and we are seeing, I believe, a change in the ordinary rhythm of urgent emergency care pathway management within the system. We will continue to have challenging times. There's a whole reason why we've got the hospital transformation programme and the local care programme in place. But at this point in time, with the oversight of the System Control Centre and the impressive response of all partners, I'm confident that we are seeing a change away from some of the characteristics of our previous flow issues. Moving on to elective care, the three primary areas of focus: 104-week waits, 78-week waits and cancer, detailed within the report. 104-week waits at the headline level, worth identifying that we continue to work towards the 104-week waits by the end of March. There is a risk around 34 patients that's highlighted within the report, but staff continue to maintain close focus on that, as we do with our favourite spinal patients at Raja, which have been a constant theme for close focus through the year. On the 78-week wait position, the system had a plan for 458 patients to be waiting 78 weeks or more at the end of March. The drive from NHSE is to reduce that to 0. We're currently, or at the point that this paper was submitted, forecasting 889, I think if we call the paper properly, patients would be waiting with an intention to bring that down. Our current plan has us at 723, but a weekly focus is reducing that, so I'd expect that to be somewhere down by 600 by next week and continuing to drive towards 0. But there does remain risk around hitting the 0 number by the end of March, which is worth the board being aware of. The main areas of focus in reducing that will be around the implementation of the new patient choice policy, the role of mutual aid outside of the system, but the existing expansion of support from Raja to Saffron Orthopaedics as well, and the additional operational grip issues that the staff is focusing, not least based on a GIRFT visit that we had from Professor Briggs this morning. I'll pause for breath there, Chair. There was a lot more detail, particularly around the cancer and within mental health within the paper, but I will take that as read and take questions.
Thank you very much indeed. Things are difficult, aren't they? And the word that we hear time and time again is challenging, and it's hard to disagree with that. I want to open it up, and I'm looking for contributions from chief executives or representatives about prospects and what you think we need to do to recover the position, or improve the position, recover if at all possible in terms of urgent and emergency care. But particularly I want to focus on elective care because the numbers you're citing are frightening. They are too big and we need to do something about that. First of all though, I thought it might be useful, Mark Doherty, good to see you, Mark. Mark, for those who may not know him, is can never remember your job title, a very senior person within the ambulance service. Let's put it, Director of Nursing, but does lots of other things as well. Mark, from the ambulance perspective, what's your take on whether we're making progress or not in terms of ambulance waits?
So I think the first thing is to say a huge thank you, although the graphs don't point in the right direction for December. I do recognise just how hard everybody is working in the system. So I think that's the first thing. I know that's not always how I come across, but firmly I do believe that. It's unfortunate that this meeting covers to the end of December and not the current situation, because there's things going on in the system now that I have never seen in my whole career in the health service, and that is...
I hope it's good things.
Well, it's good things, absolutely. So if you go back to December, we had loads of patients waiting for an ambulance and no ambulances. For the last 3 weeks, we've had loads of ambulances with no patients waiting. So as we speak now, I've got nobody waiting for an ambulance. And I know you're saying, and touch as much wood as you want. I don't know what's going on in the system, that's the problem. So we've got ambulances available, we've got demand that's reduced in Shropshire particularly, to a point where people are getting quickly their ambulance response. And the handover delays, I look sometimes, and again, just randomly this morning, I looked before coming to this meeting, there was no delays this morning at hospitals. We haven't seen that for months and months, so whatever it is, we need to just carry on doing it, but the problem is we don't know what it is. A little bit of it coincides with when the strike started. So the first Wednesday when our staff striked, some of it might be patients changing their behaviours, because we were saying just call us if it's a life-threatened emergency, and they may just be doing that because we're not seeing lots of inappropriate calls. But equally, I don't think from what I've heard we're seeing lots of patients just getting a taxi or the bus to hospital. So from our point of view, if January carries on as it has been, we had a board meeting this morning, and that's partly why I couldn't join the meeting. We're looking for the first time in over a year at reducing our risk of handover delays from a 25 down to below a 20. We haven't done it yet because we haven't got a full month of low handover delays, but the fact that that's the first time in a year I think is quite something. So yeah, January's looking a lot better than we've seen in any month for a long time.
That's very encouraging. You kind of raise a query about, I'm not sure how this is happening, and I think you then mentioned some of the factors that might influence this. A question, maybe I'm being too dewy-eyed. I'd like to think a good part of it is the hard work and effort that people put into, for example, opening the acute floor within Shrewsbury, for opening the virtual ward and using that as a step-down facility, for redefining, for streamlining the internal flow arrangements within the system. Those are all things which I'm confident have contributed towards improved performance. But you're right, we can't be complacent. Rome, as I said earlier, was not made in a day, and we've got to keep at it. And my question for other chief executives, if you like, is what's your sense of confidence about our ability to maintain this kind of progress? Nigel, you count as a chief executive on this occasion, but you and Patricia, Stacey, Neil Carr's legged it, but what are your thoughts?
I think, Chair, you used the word challenging, and I think we absolutely recognise that. I think, leading up to Christmas time, the Christmas and New Year period was amongst the most challenging we've seen over the last 3 years, I would suggest, and I think we've seen that across the health and care sector. And as Mark's described, the developments that we've seen over the last month have been really, really positive. And I'm sure you're right. I think there is a whole range of plans that have come to fruition, the joint focus on it all, which has been so valuable. I think there's cautious optimism because I think we must and we need to have that. I think the realism is that we're still under an enormous amount of pressure. We have escalation capacity still in use, and that is across our system, and therefore the pressure on people, our staff particularly, but obviously they're broader, is still significant. So I think we must focus on the continued joint working that we're doing. I'm talking urgent emergency care at this stage. I've got a couple of comments on the plan side. But I think the concern, I suppose, if Louise was here, Katrina might say the same, is that the toll on people has been significant, and therefore that's the only caution that the continued focus in the way that we need to just balance with how do we just let people balance.
And bringing Katrina, it just occurred to me when I schedule some of the things that I think we've done and good things that have made a difference. I didn't mention the work on delayed discharges, which was remiss of me. In the recent past, that's been pretty impressive, and thank you for that. Katrina.
Yeah, I think it's not usual, not normal for us to put trained practitioners into ED at the end of the shift. We regularly now put trained practitioners in at the end of the shift in ED to support the clinicians as they're going off shift. Be it nursing or medical, because invariably on each shift something happens that leaves them feeling deeply, deeply vulnerable. Looking at the data, there has been the number of admissions per day, or the number of ED attendance type 1s per day, has not dropped below our model predicted. So I would suggest we're still seeing the patients coming in, but there might be more sensible, dare I use that word, use of the ambulances, which is absolutely fine. But the other thing is, of course, a lot of work has been done to expand the walls, which means that patients are no longer sitting in ambulances, they're now sitting cohorted or arrowed within the walls, still not in ED as such, but it does release routines, which is absolutely essential. But looking at yesterday's data, we had one ambulance that was 5.5 hours delayed to discharge to log out, and we had 14 RSH, 5 at PRH that were over 1 hour. So it's not gone away. The issue is most definitely not gone away.
But even
however, it is much less. But the cost to that, the social and mental cost to that, to the teams is very, very significant. And the other thing is, in actual fact, past to say that, we have also seen a reduction in the number of people who've been off sick. So the more the more we've taken corporate staff, the more we've taken staff away from their day jobs, so that they're going around giving staff who are frontline cups of hot chocolate, the more we've actually been able to support their well-being whilst they're supporting patient well-being. But it is a very, very complex issue, and we must continue the partnership working because it's not resolved.
No, I think we'd all agree with that. Nuala?
I'd be interested to know, do we have any evidence or information around patient harm that has been caused by, such as delayed handover and indeed delayed diagnosis and so on? Because I mean that's the. So we do have that information, and where can we find that then,
so
Katrina?
We track all instances of significant delays are datexed. All the datexes are assessed for degrees of harm. They're all reported in our board papers.
Okay.
Any specific incident which happens to an individual patient that is serious is reported as a serious incident. But all the others are collected for the shift together.
Okay.
If that makes sense. But
Can you give an idea of what picture that's telling us?
The vast majority of harm is low, some moderate harm, but the vast majority of harm that's been caused is low. And we've had a couple of significant instances of harm. Patient falls in the waiting room. We've had someone, for example, it wasn't reported, I don't think it was reported as an incident, I'll have to go back and check. There was a gentleman who drove himself to the hospital. He had a cardiac arrest, and there was more. We have had instances where it's clear that if the decision not to drive became different, the ambulance service wouldn't have even gotten to us properly. We would have taken them straight through to a more appropriate receiving organisation.
And for me, I think those are the important stories. We do need to understand not how many hours somebody sits in the back of an ambulance. I mean, obviously that's why we don't want that, but it is really important that we acknowledge and recognise and understand the level of harm it causes to patients.
I mean, if I may just come in, I think what we're not measuring is the system. So you measure the harm in your organisation, we measure the harm in ours. So where yours is low, ours is severe.
You see, we need to know that.
So we're regularly going to patients who are well dead by the time we get there.
So there's a bit of a risk that this important discussion gets into the anecdotal, but it's too important for that. We need some hard data, don't we, really? And maybe we can ask Nigel, Katrina, Mark and others to see how that might be drawn together, Simon.
I wasn't sure when I was with Patricia, but one of the things I was going to say was we need a quality performance committee to pick up that with the bits rather than
that's a good point. That's a good point. Thank you. Patricia.
Just going back to the last few weeks and the improvements that's being made and the confidence that we've got going forward in terms of holding that position and indeed improving it. I think there have been three things that have really had an impact in the last 3 to 4 weeks. One has been the integrated discharge team really coming together and having a focus. So it is one team that looks at one set of the numbers with clarity around what those numbers mean. So one version of the truth, and therefore one version of how we're going to manage those individuals and people behind those numbers. With bringing together some of the systematic improvements like the acute floor alongside the scaling up of the rapid response team in the virtual ward. So rather than these being disparate silo projects, actually saying how do we converge these to get a positive bang for buck impact. What we're very good at doing in Shropshire is being really good at responding to a crisis. What we now need to do is to turn that response into something which is embedded. So we've got to make some difficult decisions about the expansion of those teams so that we can industrialise the good work that's being done. And some of that had already been seen before in terms of rapid response teams, virtual ward, but it's the industrialisation. So we've got I guess there's an element of staying firm and embedding, because a lot of the staff are running around to make this happen. We now need to embed this within teams, look at how we bring teams together in a different way so that we've got the right capacity to carry this on. So I think it's a really, really good start. We've not had the level of data and information and the knitting together of the different schemes as we've had before, but we've got to kind of follow this through, which means that we're going to have some real clarity around project support, the continuation of the support for the staff to get these programmes of work done, and then the follow through onto in terms of the other aspects of the local care programme at pace. So, because we're focusing very much on the sort of the back end. There's the prevention piece, there's the other bit that will also have an impact. But I'm really confident that we can carry this forward, but it needs that continuous focus and focused resource to support it.
Your points are well made and equally encouraging. Ian?
I'd like to believe that it is because of everything that we've done. However, I just want a word of caution, because this is an unusual phenomenon. I think we do need to get to the bottom of it to try and understand it. We need to look at it. Is it reflecting what's also happening around the country to different systems in terms of ambulance wait times? Secondly, also about 111 conversions. If you've got a high number of 111 and actually got low conversions of ambulance call out, why is that? We need to understand that. Because, the last thing I want is because of the strike is causing this. So I think we probably need to understand that a bit more, because if we can replicate the same thing next winter, it'd be really useful to understand that data.
Yeah, it's again, at that point, I'm really encouraged by the things I'm hearing, but I'm not getting carried away by this, and I don't think any of us should. We should actually see how this is able to continue for a sustained period, to believe that it's a real transformational change. It looks promising, but Julian, did you want to come in, and then Gareth, and then I want to hand over to Claire to discuss the money.
Yeah, I think obviously there's a lot of good work being done. Obviously the staff are working incredibly hard across the whole system, all members of staff and social care and voluntary services. But I think looking at some of the figures, they're frightening. The admitted time, the average, the mean wait is 1,384 minutes. That's 23 hours. That's like the mean is 23 hours. And I think on the back of that, there's just sort of a comment I'd like to make about it. It's good to put in a new process, but I wonder whether there needs to be, as well as relying on data, some review of notes and systems, because a couple of the problems I've noted, and one of them came from NHSJ, where they were saying that people are now being seen by the consultants in A&E and sent home rather than being admitted, because their time in A&E is so long that they need to be admitted. And I've noticed two things. One is that we've started having what used to come through as medical discharge just coming through with comments for GP on A&E discharge notes. It says seen by consultant cardiologist, means echo, hasn't raised, totally fine, start bisoprolol, and go, needs follow-up. And that's not, I don't think, in the right place. It should be a proper discharge note. We've always had issues with patients that go very quickly through the same-day medical assessment, where sometimes there are no notes, and my staff spend hours chasing Alison James in hospital, who's a wonderful person, telling you that there are some notes somewhere. And I've got one patient who was started on a medication in hospital, came home from it, and 3 times consultants were back saying there are no notes, he was not started on any medication in hospital. I think he must have found it in the car park. So I think there's an issue that the new systems are good, but we need to check that they're not bringing harms and risks elsewhere in the system. And I wonder whether there's a bit of going through the process and checking that it is working as planned, because my gut feeling is that it's not, and people are being turned out very quickly, and some of the information coming out isn't accurate, or there is no information coming out. And I think that could be a problem as we move forward, really.
Gareth?
I think there's 2 points. If I just pick up the data side first, this is an inexact science in terms of understanding whether we're improving or not. There is no doubt that demand is down, and the industrial action will have had a factor on that. But the KPIs, the tracking of the changes around virtual ward, rapid response, all of the beds going into acute care, those KPIs are really telling in terms of the story that you can take a judgment on about the overall impact. The difficulty is the measure at the moment that we can see the change on is the ambulance handover, but that doesn't impact on the length of wait, as Julian's just described, for admission in ED. We've still got excessively long waits for admission into a bed and then discharge out through into social care. So there's lots of risk still being carried in the system. But the KPIs, which are really important for us to know, are the things we're doing right, having an impact, and they are. But what we're not able to do yet is make a conclusion as to what's the overall impact. But to your point, we need to make sure we're clear on that. I think in terms of the changes, Julian, I'm really clear there's lots of changes being made really quickly, and necessarily so, that we definitely need to review. I can certainly pick up with Nigel, particularly on the SDEC and any of the other changes. And we've put them in at pace. We've learned, the example of Raj, I've got Stacey sat right next to me, some examples from Raj at Shropcom as well, that we've learned from as we've gone along, and we need to systematically review that. I must admit I haven't reflected on that. I need to take that away and I can work that through, but I think it's a fair challenge.
Okay, I want to ask for some advice about the 78-week waits. Just remind us of the numbers again, Gareth. We're meant to be at 0 at the end of March.
So there's two we're meant to be at. We are
we are required to be at 0 by the end of March.
So our system operating plan set out an aim of delivering 458 at the start of the year. That position has changed through the year, and NHS are really clear now that we deliver 0.
458 accepted by NHS?
It was, yeah. So we had colleagues may recall, we went through 2 system operating plan submissions. The second one had a sign-off with NHSE of 458. But that context has changed through the year, and we need to respond to NHSE's requirement to deliver 0. And that's been a relatively recent change. Both provider organisations with a 78-week target have still got some legacy issues to work through.
Sorry, I just want to be clear about this. So 458 was signed off, but NHSE have now said, irrespective of that, we need you to get to 0.
That's correct, yeah. And that's really clearly understood, widely communicated. But what we don't currently have across both organisations is a clear route to 0.
What's the current position?
512 for SAF and 222 for Roger.
So what's the total?
So walking in today, it was 723 across both. But this is a moving feast, and I'm sure that Stacey may have a slightly different number for Roger.
We've moved ours. It was originally 247, it's now 161.
Right. And it's pretty bad. And I understand the issue about urgent and emergency care and all hands to that pump and the use of beds and resources to respond to those patients. And you might question the reasonableness of the NHS England requirement to get to 0, but let's be honest, anything that moves away from 458, frankly, which is our original signed-off plan, we just can't accept that. We have to find ways of dealing with this, don't we? And now's not the time to ask chief executives around this table what we're doing to get there to 0, or as near to 0, 458 at least, I would suggest. But I would like this to be followed up outside of the meeting, and Meredith, perhaps the Quality and Performance Committee could take a part in that and give us some advice about assurance in terms of processes, etc. Because this is, I mean, it'd be the same in lots of other places, but I'm not really concerned. Well, I'm not concerned about other places. It's SDW that I'm focused upon. We've got to do better. So can you coordinate something? And I know this is, you could do without this coming from a chair of an ICB, Stacey and Nigel, but something needs to be done.
Perhaps I can just add to Gareth. My apologies, sorry. From a SAF perspective, I can absolutely assure colleagues, Katrina, Louise, all of us are absolutely clear on what we need to do, looking at all the different options. I think you talked about the different options there and what is being done. I think it's immediate, it's short term, and it's also medium term. We have got opportunities like, for example, the Planned Care Hub, the CD, the Community Diagnostic Centre. They are important as we also move into next year, albeit both their June, July time as well, so that's opportune. But we're absolutely looking at all the different opportunities that we can look at. That includes mutual aid, as Gareth pointed out. That includes use of the independent sector. We've got very little of that within our current ICS footprint, so we're looking elsewhere. And also by independent sector, I mean things like radiology reporting, which again, we procure from other different providers. So all of that is important in looking at the pathways. So that isn't an answer, and it's not providing a full answer to your question and your challenge. And just provide that assurance.
If I may add on to that, we do have that mechanism in place that you've described, that you've requested. So each week we are forensically working through with both organisations to reduce that down as close as we can. But we are not at the point today that we have plans to get to zero for both organisations. But I think both organisations are clear on that.
We're the second worst in the region.
Yeah, and every other part of the region will have faced the same kind of pressures that we face. So being in that position relatively makes me even more determined to see what we can do within our existing resources, our existing capacity to deal with this problem and perform better. That's, I think we'd all agree with that, notwithstanding how difficult it is. Who's worse?
We're in a public meeting, Chair. I do know.
Right. Scribble it down for me then. Okay, I mean, we know what the ask is. We know what we have to do. So Gareth, if you could coordinate that work, keep us appraised, please, of progress against this. And Meredith, if we could ask your committee, Meredith, ask your committee to have a look at this as well, that would be helpful.
Just in terms of recovery, because although we don't provide a huge amount of elective services, we do have services that provide RTT. Yep. We are on course to deliver what is the required no patient waiting for more than 78 weeks. In fact, we're very confident we'll achieve 52 weeks for our RTT delivered services, which mainly pertain to things like podiatry, musculoskeletal services, dentistry for complex adults and children. We also are applying to give some assurance and confidence to our non-RTT elective services, of which there are many, like pulmonary rehab, that have a huge impact on keeping people well and out of the non-elective system, the same kind of focus in terms of weight. I think the point that I wanted to make is obviously we're a small player in terms of the elective element, but nonetheless I think there are certain elements of our services that could help support and alleviate, such as the front-end musculoskeletal triage process that can take out 70% of care.
I mean, that's great to hear, but why has it not been brought into play?
So for
we've
example,
got a crisis?
Maybe one waiting list across the system for different elements so that we can move patients to the appropriate capacity as needed and required. There's the MSK pathway, which I know Stacey's very keen to implement, so that will help some of the issues related to musculoskeletal, which is going to be a large proportion of the waiting list. It's not the main proportion, but it's certainly a large proportion of that. And thinking differently about how we manage both the process of demand and treatment for people, as well as getting the treatment.
It's great to hear those ideas, those glimmers of possibility, but my frustration is, I mean, it's not as if that's an idea that's just emerged. It'll have been around for a long time, and here we are talking about it with just over 2 months left before the end of March. Why don't we pick up these things and implement them sooner is my challenge for us all, really.
Just, if I could just come in, Neil. So in relation to Robert Jones, Agnes Hunt, from a long way to the 78, again, we're down to spinal. So we do not have, we have a small handful which we are confident will be treated way before the end of this financial year. From an MSK perspective, we're now down to similar issues that we had, which we knew we would have, as we did with the 104s. So we've got 3 specific asks back to the region, to NHSC, to help support some of that, having explored everything that we've done and improved. We've improved our picture from our original trajectory.
Okay, thank you. An awful lot of work to be done. Much more collaborative work needs to be done. We need, Gareth, to have your advice on behalf of everybody about what the plan looks like. It's too late, isn't it, at the next board meeting at the end of March to have another detailed discussion about this. I think the board needs to know as soon as practicable what we're going to do to get those numbers down and reduced dramatically. Okay. Roger?
All I would add is and into next year as well.
Well, indeed. You're absolutely right. Thank you, Roger. Julian?
Yeah, I don't want to labour the same point again, but I'm going to labour it. It comes down to information to patients, because I get letters back, Stacey, from Robert Jones telling me my patient's at P4. I look at them
sorry?
a P4, priority 4, which I say to them, I think that's a never end. I don't think you're going to get operated on. I think that, you know, P1, 2 and 3s fill all their lists and there's no P4s, but we don't have that information to tell people, and I think it's sort of frustrating for, you know, and I think I can know why it's happening, and I know we need to make efforts to do it, but I think we just need to be honest with people and tell them this is the realistic wait. Going back to waiting times for diagnostics, we had a bonkers GP bulletin which said in it that SAF are reorganising their echoes and there's a shortage of staff and they're all going on to single sites in PRH and there's an 8-week wait. Followed 2 articles down by one from Physiological Measurement saying that they haven't had any referrals for echoes and they've got a 1-week wait. And you think, well, actually our referrals are handled by RAS and TRACS. Why have we got a provider that can do an echo in a week when we've got the hospital writing to us telling us there's a 6 to 12 week wait and they're having to reorganise their system? And I think there is a lack of joined up thinking a single list for orthopaedics. I mean, that's about as, if you say that, it's frustrating because that would be a really positive thing to have. And I think there may also be an element that at least patients would also be would know whether they're P1, 2, 3 or 4, 5 or 6. They would also know that the chance of being uprated or upgraded is done on an objective basis across the whole system, and they have an idea about when they can get their operations.
Any thoughts about that, Karen?
I concur. I think we're in a really difficult place, and we've got to deal with the issues that Julian's described. I couldn't disagree.
So, some causes for optimism on urgent and emergency care, but beware. There's a lot unknown, but well done, everybody. Improvements have happened, and there seems to be good reason for many of them, and that's very encouraging. Concern and a bit of consternation from me at least, and I think from other members of the board about the 78-week backlog. There is more needs to be done. It sounds like there's more we can do, but we're going to have to get our skates on. And let's be clear, anything over and above 104 weeks at the end of March is just, any suggestion of that is completely unacceptable. Okay, let's have the great news about finance, Claire.
Just to cheer us up.
Yeah. Dear me, I don't think I can be the ray of sunshine you might want. So I think it's fair to say, and similar to comments that I've made in previous meetings, our financial position very much reflects some of these difficulties and challenges that we're talking about. We quote in the paper here our month 9 position, so at the end of December, and we are already in a place where we have a £29 million adverse variance to our plan at that point in time. As you can imagine, that has a significant effect on where our forecast outturn will land, and we remain in conversation with both the regional and national NHS England teams about that, and Simon and I have been meeting regularly with the National Director of Finance, and we're due to see him again on the 3rd of February to talk through the actions that we're taking to try and contain some of this excess above plan, particularly now, given we're so close to the end of the year, with an eye on what that means for our underlying position and the move forward into next year. So very much pertinent in terms of some of the comments we've just been making about embedding the good practices that are happening, some of the concerns flagged earlier in the meeting around discharge funding and our ability to purchase sufficient capacity to keep up the work that's happening there. The drivers of the overspend, again, I'm not going to dwell on those. They're very, very consistent with what we've been reporting all year. So we do have a set of market pressures that we see, particularly through the ICB and CHC, where it's most prominent. And we have been able to mitigate that through use of unlocking balance sheet and non-recurring funds. But I think of note are the other items that we mention in the report, particularly around the cost of discharge and also that cost of escalation within SAF. We are talking about multiple millions of pounds of escalation capacity in the hospital, and that's one of the really core drivers of that movement from plan. You'll see reflected in the people section some of the vacancy rates, the sickness rates, the challenges we have, so that escalation comes at a premium cost because we're having to bring in agency and locums. So it really is absolutely in our interest from a financial perspective for us to be driving those discharges. It's absolutely the right thing to do for the patients. Of course it is, but it will also help to improve the bottom line, and most importantly for me, on a recurrent basis, so that we can start to get into that financial recovery space. Just wanted to flag as well, it's not in this report, but just to give some assurance that work is well underway on the finance plan for next year and beyond. We're not just looking at 1 year, we're trying to make sure that we've got that longer term period, and we'll be taking some of the initial cut of the numbers to Finance Committee next week, so we'll be starting to have a look through those, and certainly board will see that very shortly as we start to assimilate that, particularly with the activity and workforce plans, because we're not producing that finance plan in isolation. Probably all I was going to say, but I'm happy to take any questions.
Trevor, any comments from the Finance Committee perspective?
No, I think only really just to emphasise Claire's point around the longer term planning, because I think a very strong feeling that if we're going to make a real difference over a 5 to 10 year period, then we've got to start thinking now about what we want to look like in 5 to 10 years and start prioritising the finances towards all of that, because I can say this as someone not in the heat of battle every day within the NHS, that actually if we're just almost stumbling from year to year, then we'll never make those substantive changes. And I think that's something that very much comes through the finance directors, and we need to feed it all the way through, and actually relates to a lot of what we've just been talking about. Again, somebody sitting almost from the outside now, data is key. We've talked about that 2 or 3 times today. And if we haven't got that as a key enabler in our forward plan to make sure that we have better data and better shared data, then none of this decision making will be happening. You know, if we were faced with the improvements that we've seen in the last 3 weeks, in 5 years' time on something, can we be in a position where already we'll know why it's got better? Because at the moment we don't, the conversation I've heard, we don't really know why things have got better in the last 3 weeks. So what are the levers we need to pull? So relating back to the discussion around the forward plan, I think it all comes together.
Thank you. Claire, anything you want us to do as a board in terms of the financial position? I know every organisation in this room is heavily focused on the financial position and the drivers that are creating the pressures in a couple of our organisations at least. But is there anything else you want us to do today?
I think from my perspective it's not particularly an ask for today, but it's to make sure that we keep this live and at the forefront of our discussions, certainly also supporting Harry as chair of the Integrated Delivery Committee, because if there's 2 things that I need to help improve the finance, it's pace and delivery. So that's what we need that support for.
Pace and delivery. Harry, your card is marked. Thanks, Claire. So some real anxieties in terms of the financial position, but thinking longer term, I think, is absolutely the key. And we've talked a lot about prioritising and making sure that we know that which we want to invest in, and frankly the areas where we need to have lesser priority. Katrina.
I think we can describe why things have improved over the last 3 weeks. There's definitely some elements which without doubt need to continue. And Patricia has highlighted them with regards to the greater working that's been done in a very much improved integrated discharge team, etc. We have actually also had increased discharges into the community, and our council colleagues have already indicated that might not be sustainable. So that's something we have to keep in mind. But one of the other reasons why we've been able to improve is because we've actually stretched the walls. And we have got areas of the hospital that have got patients in them that ordinarily would never have patients in them. And we call them areas of escalation. And in the paper it says escalation areas remaining open due to COVID. They're not due to COVID.
they're due to the urgent and emergency care issues on the back of the medically fit for discharge issues, etc. So this isn't an acute care issue. This isn't a community issue. This is us really needing to find a way for us to reset where the money should be spent to optimise the care of the patients. And I would argue that it's probably not in the escalation areas of a hospital, which are remarkably expensive.
Absolutely.
So I think we do know why things have improved over the last 3 weeks. I think we do know there's 1 or 2 areas that are potentially sustainable. We know there are other areas that could be sustainable, but at a cost that I think is inefficient and would be better spent elsewhere. And there are, a lot of this is at a mental health cost for the practitioners who are actually dealing with this on a day-to-day basis. So I think as part of the long-term plan, I suppose my first question is, and don't answer it please, is where does all this escalation fit into what the 23-24 finance is going to look like? Because I can imagine what the answer is going to be, so please don't answer it. But the second one is, how do we actually answer it differently? And if you want, I'd rather pay 150 or whatever it is per night through the councils than 300 through me, but I'm not allowed to give the councils half my debt, if that makes sense. So it's how do we actually work it so that the right monies are spent in the right place and we're all de-escalated as a consequence of that.
Okay, unquestionably, a lot of the plans that we've been working on, a lot of the hard work and effort of staff have brought about some improvements during the last 3 weeks or so. But in defence of Trevor's comments, because I heard the same from Ian and from Mark, there are some imponderables that are difficult to explain in terms of activity, for example. But nonetheless, we're making a better job of urgent and emergency care now than we could have expected a few months ago, and that's brilliant. That's very creditable. Okay. Yeah.
But I suppose my question for yourself and for Claire about just I know I wouldn't like to be a director of finance because you look at the past, the present, the long-term future and the medium future, but obviously with the new the information from NHS England about the changes, the proposed changes to the financial regime for next year, with moving to sort of block for emergency, I think, and then PBR effectively for elective care, and then looking also at SAT's slight underperformance in terms of plan. When are we going to see some paper coming to the board about next? Because obviously our next board meeting is March, which is obviously just before April. Are we going to have I'm sure it's gone to the finance committee. I'm sure the finance committee are on top of this. But are we going to have some information to the board around the financial plan for next year and how we might have to manage if SAT's underperformance on electives continues? How we might help them manage that underfall in their income? Because presumably that's what you touched upon, and it probably won't work on paper.
So there's 2 things in that. One is yes, absolutely, the board will have lots of information, and as you describe it, through finance committee and alongside the activity and workforce and operating plan, not just the finances. So that will come. The other part about the mechanics of the contract for next year and how that might impact on what we're doing is actually a very live topic at the moment with the directors of finance. So we have a subcommittee of the finance committee, which is currently the Intelligent Fixed Payment Management Group. Predominantly the directors of finance, because it's quite a technical meeting, but it basically helps us to operate that arrangement. And we have a paper coming to that group which meets on Friday to talk about exactly what you've just described. There's a different regime being consulted on. It's more than likely that it will come through. What are our options as a system for how we use that moving forward? So very live, Julian, but we're not quite ready to give you an answer, but it will come.
Okay, thank you. I'm going to move us on. Thank you for your contributions. The next item is the transfer of pharmacy, optometry and dentistry. We've had a bit of a discussion about that previously. Claire Parker isn't here to present it. Gareth, I presume the papers are self-explanatory.
They are, yeah, and we gave a good run through in the Chief Exec update, so there are some specific approvals that we need to make, but with your permission I'll take the paper as read and...
People happy with that? Yep. Everybody okay? Thank you very much indeed. And then we have the Governance Handbook Amendment to Scheme of Financial Delegation. Claire Skidmore.
Thank you, and this is a very brief item as well. So we've now been operating as a new organisation for a number of months. We've found a small area of the financial scheme of delegation that actually has been quite restrictive operationally. So we took a proposal to Audit Committee last week to do something slightly different. We've tested it. I've had a look at it with the team. In my opinion, it doesn't take away any financial control that we've got, but it will allow some more flexibility for the team. We'll obviously provide any training that's required to any new budget holders under the regime, but we just need to have it approved here.
And I see the thumbs up from the Chair of Audit. You're happy with that, Roger? Yep. Everybody okay with that? Thank you very much indeed.
Thank you.
Now moving into the committee reports, and I'm going to ask you to take the various reports as read, but I'll quickly ask the chair of each committee if there's anything that in particular they want to raise. So if we look at quality and performance, Meredith, anything in particular over and above that which we've talked about today?
Much of what we've talked about today, actually, so I don't think there's anything that I'd like to draw out in particular.
Thank you. Finance Committee, Trevor, anything else you want to add?
Covered it.
Fine. Audit and Risk Committee, Roger, anything you want to draw out?
No, it's all right.
Everybody happy with that? Thank you very much indeed. And then we have the REMCOM.
Yeah, again, as read, so unless anybody has any questions.
People happy with that? The Strategy Committee Chair's report for a meeting held on the 15th of December. Kathy, anything you want to draw out? We've had a lot of discussion around strategy in the planet.
That's fine.
Are you okay with that?
Yep.
Yep. Any comments for Kathy? The System People Committee Chair's report. Katrina, anything you want to say?
This is the written report of the verbal I gave you last
This is what, sorry?
This is the written report of the verbal I gave you last time.
Okay, thank you very much indeed. This is great. Primary Care Commissioning Committee Chair's report. Nicky isn't here. Nick, did you want to...
Nothing to add on this.
Everybody okay with that? Thank you very much indeed. And then we have the Integrated Delivery Committee Chair's report for 2 meetings. Harry, anything you want to add?
I think just 2 things, Neil, to support what we've said and deliver against your pace request. But one is that on the finances, we shared your concern, and so we agreed that Gareth would mandate leads in the organisations who the Integrated Delivery Committee would hold to account personally for delivery, and that's what's happening now, Gareth, I think. And the second thing is on the 78 and 104s at the last meeting, we agreed that we would do a deep dive into these so we could report in more detail what was going on.
So help me, I thought that was probably part of the remit of quality and performance, but you think it's within your...
Well, I
just want to be clear, that's all.
It was... Go on, Gareth.
Yeah, it's one of those areas which is both. So the Integrated Delivery Committee reviews the function of the Planned Care Recovery Board, which is very much the front and centre of it, but obviously with quality and performance, overseeing performance as a whole, it does have the same report going to both committees.
So in terms of thinking about recovery, it sounds like it's your committee, Harry, that's already on to that.
We're on to those 2 specific areas, yes.
So Meredith, my request to your committee might have been...
I think we can legitimately seek assurance that the work that you're expecting to see has been done.
Yeah, okay, that's great. That's very helpful. You okay with that?
Yeah.
Thank you. Very good. Integrated Care Partnership minutes of the meeting in October-December. The December meeting was dominated by the preparation of the Integrated Care Strategy. Is there anything people want to raise? And then we have the Clinical and Care Multi-Professional Leadership Report. Nick? Alison?
This was in response to an action last time about how to report to the ICB board and ensuring that the clinical voice is being heard. So we decided we'll take a few steps just to make ourselves even more visible. Always apologise for the acronym CC.
I know, it's a terrible one. I can never get back.
It makes sense. It is about clinical
of course it is.
Multi-professional care leadership. But it's a mouthful and it's NHS England, and we use it when we respond to them about our CCMPL. One of the suggestions going forward is we change its name to the Clinical and Professional Cabinet, which is ideal. Myself and Katrina and Louise stole an interview we were doing in December. One of the candidates said that's how they do it in their neck of the woods, so I think that would be a good name. We've got a Senate, so why not have a Cabinet? It might have a clinical leadership, professional leadership, you know, feel a bit more self-empowered. That's now comfortable that all the senior clinical and professional leaderships, you know, their voices are heard at the board. But what we'll also do is when we have we don't have an agenda of a slide deck, but after the meetings, which are monthly, we'll send a slide deck out to the CEOs within the system, and rather have the actions from the previous meeting as to follow up, we'll actually put the actions going forward so everybody's cited and what the discussions are.
Thank you very much, Alison. Do you want to add anything?
No, that's covered it all, thanks.
Any comments, any questions? Everybody okay with that? I've not been notified of any other business. The next meeting is the 29th of March, and I hereby declare the meeting closed 2 minutes ahead of the revised timeline. How on earth I've managed that, I have no idea. A bit like urgent and emergency care. Thank you very much indeed, everybody.
Thank you, Chair.